Live from New York, it's Benefit with Friends. I'm your host, Lou Bernardi. Welcome, everybody. Hopefully, you're having a great day. Hopefully, there's people out there. I can't actually see from this side if anybody's live. I know there is one heartbeat out there, Kelly Webb, my guest speaker today. So I'm going to have him come in a second. But the title of the show, Benefit with Friends, and that is really what we're trying to do is create a network of people, hopefully benefit decision makers. It's kind of my code word for HR directors, chief of people, CEOs, CFOs, COOs, anybody who's involved in the benefit decision making process these days understands how complex things have become. This is my 30th year in the business, selling employee benefits, group health insurance in particular. And I know that things have changed significantly, not only the products that we sell, but also the healthcare world, the health insurance world. I think it's become deliberately complex, and too often we're making decisions that are reactive instead of proactive. And so I wear these silly shirts. If you're new to the show, BOO, Benefit Optimization Officer. That's what I see myself as, is trying to help companies optimize their benefits, which for me is enhancing benefits, improving outcomes, and as a result, lowering costs, not deliberately going out there to save, because you can do that in a lot of ways. In many ways, that approach has resulted in the type of benefits that many people have today, very high out-of-pocket costs. Last week's show, my guest, Aaron Whitwer, and I talked about the functionally uninsured, which I would classify pretty high percentage of people out there that have migrated onto plans. If you're in the small group market, silver, bronze level plans, high deductible plans, and there's nothing wrong with those in and of themselves if they're packaged with other type of solutions. There's way too many people that are have migrated or evolved into plans that they really aren't happy with and they don't know how to get away from. And there is an entire universe, as I've found out the last 5 years of my career, opened the door to an entire alternative universe of healthcare and health insurance. Benefit optimization to me, as the name implies, and this came from HR Daily Advisor, it's not my definition of it. It's the process used by HR professionals to critically assess the organization's benefit structure and determine what changes can be made to make the benefit package on offer best serve the organization and the employees. And I know HR directors, CFOs, CEOs, they're good people. They really care about their people. And I think in today's world, because of the Great Resignation, they need to show that, right? They need to put their money where their mouth is. It's hard to retain employees. It's hard to get people to come back to work. And I think, the fact that the health insurance plans of the world today have gotten so off track, if you have a keen set of eyes and you have, partners that you're aligned with that understand how to get it back on track, there's a lot of investment in that. It's the second or third largest investment that companies make, and the number one investment they make in their people. We can revamp that. We can repurpose that money in a smarter way that allows us to offer richer benefits to people. I've kind of identified, for my purposes, 8 core issues with the status quo listed here: lack of price transparency, lack of quality transparency, low provider patient engagement, excessive prescription costs. We've seen as much as 53% overcharge in prescription costs when we've run pharmacy analysis for some of our prospects. Healthcare steerage, misaligned incentives, no control of the plan document, and a lot of unnecessary care that's part of the healthcare system. And there's a lot more than this, but these are some, solutions. These are kind of categories of solutions. Care navigation. We need to get people to the best providers, not the cheapest providers, the best providers. How do we do that? That can save a health plan a lot of money, but more importantly, keep people well, keep them healthy, keep them out of the healthcare system. We need to create incentive-based plan designs, transparent open networks, plan document control, direct contracts, independent TPAs, pass-through PBMs, and enhanced primary care. And today I'm going to bring into the room right now Kelly Webb of ESurgeries, or Exclusive Surgeries Solutions. Welcome, Kelly. How are you?
Thank you. I'm doing well. Thank you very much.
Yeah,
Glad
well,
to
thank
be
you for
here.
joining me today. I forget, where are you joining me from?
I'm in the Phoenix, Arizona area.
Oh, that's
Actually,
right.
a city called Peoria, which is just right next to Glendale. We're just down the street from the Cardinals football stadium.
Well, very nice.
Yeah.
Not the Cardinals. I don't like them. I prefer the New York Jets or the Giants, but that's okay. And I should have known that because you gave me some restaurant recommendations when I was in Scottsdale last month. So we're going to talk about direct contracting. We're going to talk about your world, and I put that under the category of direct contracts, which a lot of people out there. I'll get rid of this slide now, but people. I guess that are just kind of consumed with the traditional status quo insurance carrier products. This is an example of one of those things that most employers, especially I'd say employers less than 500 or less than 1,000, don't even know exist, right? Direct contracts.
They get kind of caught up in the fact of all the branding that goes on TV if you look at it. I mean, I've seen tons of commercials where they talk about different branding from different insurance companies, and people think that they're getting the best doctors through this branding. Well, the reality is any given surgeon, any given board certified surgeon or doctor, they are contracted with almost everybody they can get in touch with. So they belong to the Cigna network, they belong to Blue Cross, they belong to United Healthcare. And guess what? They belong to our network of exclusive service solutions because they're board certified, great doctors. They're focused on patient care, and that's what they want to do is take care of the patients.
Right.
And
Isn't that what I think hopefully most doctors want? And I think the managed care system gets in their way. And I'm sorry I cut you off there for a second.
No, you didn't cut me off. You're actually helping out in the whole discussion because the reality is exactly that. I've talked to so many surgeons. Our whole background has been in billing for surgeons nationwide. Our previous company was about billing for surgeons to actually get paid by the bucas, and we learned dramatic lessons from that as to how they stall, delay, underpay, deny, and don't want to pay these surgeons. But the point of that whole discussion is these doctors are out to treat their patients. They really want to treat the patient. Now, there's two types of doctors, there's more than two types, but one of the main focuses of doctors in the system is those that are owned by the hospital system. And what do I mean by that? I mean, if you go to a surgeon or a doctor who the local hospital in your city has purchased part of his practice, we call that a hospitalist because that doctor, he has share interest in his personal practice. People come to see him for a consult. He's going to refer them to that hospital down the street.
Right.
That's a hospitalist. But you have other independent board certified surgeons who focus on treating the care of the patient, and they literally want the best care for the patient. And sometimes, as you mentioned, that gets in the quagmire of the hospital says, no, you're going to do this procedure in this way and bill it for this in this fashion, and we're going to get paid this amount of money. And the doctor goes, hey, I need to do other things here. And they say, tough.
Yeah. Well, so, it's funny because in the book I'm writing, and it's taken me quite a long time because it's complicated and I'm learning things every day. But one of the things that I realized as I looked back and said, okay, what's changed about managed care since the early 90s when it kind of, it started from the West Coast and kind of came up the East Coast. So got here later than other parts of the country. But what's changed so dramatically is that the healthcare systems, first they merged horizontally. They merged with other hospitals, right? They said we need leverage. We need partnerships so that we can fight the insurance carriers' contracted rates. We're not getting enough money. They're beating us up because they represent millions of patients. We need their patients. So the hospitals got together, they joined, they became pretty strong. And they said, good luck trying to sell insurance if you don't have our hospital system because we own the whole area.
Yeah.
Then they vertically expanded, and they started taking over the specialist groups, the urgent care centers, the ambulatory centers, and then they got all the way down to the primary care doctors, and that's dangerous. And the reason why it's dangerous is those doctors, and those are the ones when you pull up to their building, the name of the healthcare system's on their building. right? Those are the ones that are employees of the healthcare systems, essentially.
Right.
They're the feeder network, right? They
Right.
are
Exactly.
the hospital system doesn't want anything to escape their net, right?
That's a true statement, and it has done that. And yet, I want you to step back and take a look at that cycle you're talking about, because most of these doctors are they're not very good businessmen, but they really love taking care of their patients.
Mm-hmm.
And there's been a cycle in the United States, and we've seen it in the last 50 years, that the hospitals come in and buy these practices of these surgeons. They buy all the way down to primary care, just like you described. Then they're kind of owned by the hospital. They're back to doing rounds. They're back to doing patients. They have to perform in a certain way. All that administration. There are so many doctors that'll do that for 3, 4, 5 years, and then they get tired of it.
Yeah.
They leave. They sell their practice part of it. They go out. They open a new office and said, "No, I'm not going to work with XYZ brand hospital system anymore. I'm independent. I've been in this long enough. I'm the best orthopedic surgeon. I'm the best hand surgeon. I am the best urologist. I'm the best OBGYN or vascular, you name it." And they open their own door, and they open their own ambulatory surgery center.
Right.
And they say, "I've had enough with the systems. I want to focus on my patients and do what I know I need to do to treat them the best I can."
Right.
So there's almost 5,700 ambulatory surgery centers in the nation. And that cycle you just talked about, it comes and goes. They might recruit young doctors to work in the hospital for a while. They might stay there for a while, and eventually a lot of them will leave and go out and branch on their own. But there's 5,700 freestanding surgery centers. And the word ambulatory, Lou, we were talking about this earlier. Ambulatory means walk in and walk out at the end of the day. I had one person say, "Well, do you have to go there in an ambulance? Is that why it's called ambulatory?" And that's a sincere question.
Yeah, absolutely.
They didn't understand. But it is for common elective planned surgeries.
Right.
So let's look at some of those. For example, a scope of the bladder, or tubes in the air, or hernias, inguinal hernias, or umbilical hernias. All of these are very common surgeries, and they can be done in a safe environment at a freestanding operating room is what it is. It's an ambulatory, and it also means there's no overnight stay in most cases. They literally, you walk in and go home to recover at your own home. Now, what's so great about that? Well, let me hit 2 highlights, or 3. First one is it's run by the board certified surgeon. He's got his consistent staff. He knows where everything's going to be. He really loves the setup. And he also, by license, has to have a registered nurse that's running that facility.
Right.
So the other thing is that's really huge right now in our society is there's less than 1% infection rate in these ambulatory surgery centers nationwide. So people are scared to death of COVID. They're not going back to hospitals. They're staying out of hospitals if they can, because MRSA's there and everything else. But I mean, if you know anyone that's having a planned surgery, my recommendation is they first consider going to an ambulatory surgery center, because it's less than 1% infection. What does that mean, Lou? That means they're not going to get a secondary infection from the surgery itself. And that is a danger at some of these old established hospitals. The hospital systems, they do the best work they can, the best thing there, but some of them have a problem with MRSA as high as 10 and 15%. I've seen.
Wow.
It is published information on a hospital's website by federal law. You go dig deep enough, you will find their infection rate. They have to publish it. But if 1 out of 100, if 10 out of 100 people, or 15 out of 100 get a secondary infection, and we're talking MRSA, staph infection, methicillin-resistant staphylococcus. I can't say that word.
I don't want that one.
That is MRSA.
Sign me up for the other. Well, I'm gonna go ambulatory if I can. Anyway, I'm gonna pull up a PowerPoint. Because you shared some information with me, and I, for the purpose of this call, I can't really put a ton of it there. But this slide we're really familiar with, right? It's just the average worker employer contributions and premium. So this kind of sets the tone for there is something wrong with the status quo, right? The average employee contribution to their health insurance plan has increased by 300% from
Oh,
over
easy.
300%, right?
And notice that that's at 20, it stops at 2015. We don't have more current data on this, but you can just see the bar graph going up. There used to be what was called 90-10 plan splits. That's where the employer paid 90%, the employee paid 10%. Well, most employers cannot afford that anymore. It's
Right.
got so expensive. In fact, Mary Ibarra, the president of General Motors, said that they're not even a car manufacturer, that she said that they spend more money on their health care plans for their employees than they do on steel.
Yeah.
And so that transition has changed now. There's a lot of companies don't have 90-10s. They
Right.
have 50-50s.
Yeah.
Where they're paying 50%, the employees paying 50% of the cost. The costs have gone up. The hospitals are still billing and getting paid. And so, yeah, it's gotten expensive.
Well, that's, so that's the thing, I want to talk about that for a second, is because there's another grid, and I don't have it here, but I've shared it a couple of times, where employee contributions, and it's a little bit more current, right, than 2015, but employee contributions just in the last 2 years have increased by about 200%.
Yeah.
Right? That's contributions. Their out-of-pocket costs have more than doubled, right? The average premiums have doubled in the last 10 years. Everything's doubled. And that's with the watered down benefits. What would have happened to those premiums and contribution shares had we had a static benefit where you couldn't change it anymore? And we're kind of at that point. To your point, a lot of employers have already hit the ceiling. That's why this is the the bubble is bursting, because we've hit the cap. They're at the $7,000 family, individual deductible on an HSA compatible health plan, $14,000 family. They have nowhere to go. They can't water it down anymore. And most employers, as you mentioned, have, in addition to the out-of-pocket cost, increased the members' contributions, right?
Absolutely.
So you got worse benefits. You're paying more for it. It's that whole get less, pay more results that that we've all approached. So the good news is there are solutions now. Your company, and we'll get to this chart in a second. But your company, just so that people out there understand, you can do, if for a self-insured employer, an employer that is self-insuring their health plan. And if they're doing it with the right partnerships, where they have the flexibility to have, even if they're using a network still, let's say they're renting Aetna's network or Cigna's or Anthem or United Healthcare. As long as you have the flexibility to have direct contracts, other partnerships in place, so you can control that plan document, back to that list of solutions that I talked about, so that when an authorization has to come in for a surgery, which it almost always has to, even outpatient, right? I mean, it's got to be medically necessary. We want to protect the patient, make sure it's appropriate, right? At that point, now we use case managers, right? We have an excellent case manager. I'll give them a little promotion. Engaged Health, a clinical nurse who's reviewing all of those utilization notes from the insurance carrier and proactively reaching out to that member at that point. Hey, we know you're getting the surgery. Would you like us to help you to make sure that you're getting the best care, the best surgeon, whether it's in the Aetna or Cigna model or not? But also, if now using your model as a supplement to that plan, or as a carve out, right? So that we're carving it out, and you must use, right? We feel so confident that your doctors are the best doctors, and not only that, the benefit is we probably get a better price, maybe significantly better, probably, right?
Yes, because we got to probably delve into that just a second, because what happens is we're working with board certified surgeons. Remember, we talked about the surgeon who said, I'm established. I've been in this industry doing this surgery, and he's done hand surgery for the last 5-10 years. He knows what he's doing.
Right.
So he started his own ambulatory surgery center, and he's been screened. I mean, we go through this checklist that we verify that these surgeons are very professional. They're board certified. They meet all of our standards, and just really take a deep look at them and find out what they're doing. And as we find them, they're some of the best of the best. In fact, we have surgeons we're utilizing that people fly in from China to do spine surgery with. And in fact, in New York, we have the orthopedic surgeon who's also for the Rangers and the Mets. The Mets, yeah. And
Yeah.
I'm going to throw this in there too. He also told us he does work for the Giants football. Yeah. So the concept there is these gentlemen are some of the best in the industry, but they have a smaller setup. So they're not, the hospital has to pay an awful lot of money every month for just the electricity to turn on the place. They're huge buildings, cost overheads, all these expenses are running the thing. The doctors, surgeons at these ambulatory surgery centers are a smaller unit, but the level of care is actually probably higher than a hospital. Why do I say that? Because you got one-on-one service with the registered nurse. You got one-on-one service with the techs. You have a workflow that goes through, and that surgeon's going to work on you. You're the only patient he has for the next 3 hours. And, you just feel a whole lot different. I've had other clients say, wow, this is how healthcare should be, because, boy, they really took good care of me.
Well, talking about when kind of leading in when I was talking about managed care and how complex it's been. If you're out there, just take a second to think. Today, you find out either yourself, a loved one needs a surgery, maybe even a life-saving surgery. Anything significant, a knee replacement, a hip, a shoulder, an elbow, like something that is going to stay with them for a very long time, or something much more serious than that. Where do you go? How do you pick your doctor today? How do you pick that surgeon? Is it a recommendation from your primary care doctor? Is it a recommendation from who? Like, how does someone know that they found the best doctor without it being a company like yours that vets them?
Well, I'm not really certain. It takes a little bit of work. And the first thing you have to get over is the white coat intimidation. Doctors spent 10 years becoming a medical physician, and they're good, and they control their room. And when you go in there, they like to manage their space, and that's all good. They're that type, okay? And that's fine. But you need to ask all the right questions.
Right.
How long have you been board certified? What types of surgeries do you specialize in? Here's an example. The orthopedic surgeons are so specialized nowadays, you do not go see the same orthopedic surgeon for your hip that you would go to see for your hand, or go to see for a total knee replacement. You don't want to see the total knee guy when you're doing a hip.
Right.
You want the guy who's done 5,000 total knees to do your knee surgery, because he's so skilled at it. He knows exactly what to do to take care of you, and he knows about your gait, and he knows about how long everything needs to be, and he does all his measurements, and he's a very good professional. But literally, there's so many different areas of these elective ambulatory surgery centers. You can breast reconstruction, cancer surgery, skin surgery, spine. People have a lot of problems with their backs these days, but spine fusions, those are actually done in this walk-in, walk-out type surgery. Yeah, there you go.
Yeah, this is just very generic. This is just categories. Yeah. There's hundreds of procedures that fall under these.
Actually, there's 5,000 CPT codes that go under this. So
that can be performed ambulatory.
Yeah, and it's so detailed now. It's not on this list right in front of us, but the AMA and the government has approved that a pacemaker for a heart can now be replaced in an ambulatory surgery center.
Wow.
So, and one of the most common ambulatory surgery centers that the public might be aware of is the LASIK surgery ophthalmologist doctors. They're doing cornea transplants. They're doing cataract removal. They're inserting a new lens. They're doing all the blepharoplasty as well as laser surgeries. Those are all occurring in an ambulatory surgery center environment, and the patient goes home at the end of the day. Wow. The other one is your plastic surgery reconstruction for burns and like firemen a lot of times get hit in their forehead and their eyes, and they'll have orbital rim repair. That goes usually through a plastic surgeon. Mastectomies, cancer, breast reduction, tissue expanders, paniculectomies. So a lot of people that have done bariatrics want to have excess skin removed. That's done in an ambulatory surgery center. You have it done and you go home. So pain management, podiatry, these doctors are just really good at what they do, and their staff is very professional, and you're treated so well. You want to get the surgery, go home and recover, and people actually recover quicker in most cases.
So now you're one of the other things, again, I don't like to, well, I do actually. So hospitals, right? So hospitals, you talked about that overhead, right? They have, the CEOs of some hospitals are making in the millions, if not tens of millions in some cases, right? They're making an exorbitant amount of money.
Yeah.
I'm part of the Health Rosetta, and Dave Chase likes to mention a lot, and I love it, is 26 cents out of every dollar actually gets to the provider of care. 74 cents goes to administration, artificial prices, golden parachutes, all of those other things. Doctors are not permitted to own hospitals, but doctors, I'm pretty sure, are permitted to own ambulatory surgery centers.
That's
right?
correct.
So you're eliminating. I'm assuming the CEO of most ambulatory surgery centers doesn't have a $10 million annual income. I would imagine.
No.
Don't you want your healthcare dollars going to the providers of the care, right? That have some say in that care, and that's probably why the results are so much better. Is that because they can recruit the top talent? They do the same thing in those facilities. I'll give you an example. My gastroenterologist, I mention him on just about every show. He has his facility, his office where he sees his patients, does his consultations, and on the second floor he owns the ambulatory center.
Yep.
Right? He has one or two operating rooms within that facility. He has a recovery room. If I had to guess, there's probably about 12 beds in there. Looks just like a hospital recovery room. You got the curtain, it's no frills or anything like that. And he was independent, and he was going to be in my book because I think he's one of the best doctors I've ever seen. I went there for the first time. He spent an hour with me just talking about my health, not my colonoscopy. This was before the colonoscopy.
That's the kind of focus I was talking about.
Yeah.
Go there and they zero in on you and really actually let you know they care about you and your body and what's going on, and answer your questions. And the concept is that even that GI doctor, they see quite a few people in a given day, but they are fighting to actually get paid. In fact, we've been in billing for years, and what we've seen is that all these insurance companies and everyone else are just cutting the actual doctor's money down more and more almost every year. It's incredible even surviving.
So give me an example of a cost differential. If you have, the price of the same procedure done inpatient versus, or not even inpatient, at a hospital, and you're going home the same day, right? At a hospital versus an ambulatory surgery center.
Well, it could be really dramatic. I mean, we, like, for example, on total knees, total knee procedure can go for, in a hospital, if you go to the hospital for total knee, they like to keep you there for 2 or 3 days to observe you. And so that tends to run the bill up. But we've seen bills as high as $380,000 for a total knee at a hospital. And that same exact surgery can be done down the street in the same city with a board certified surgeon in his surgery center for right around $84,000. Now, people hear those numbers and they think, oh, wow, that's just so much money. Well, $84,000, a lot of that money that goes in there is for the implants themselves. The actual metal implants or the device that's in the knee, there's an awful lot of expense in that. We just had a meniscus tear, and there are like 3 plates and 2 surgical screws, and the bill for the DME came to $10,000 for just the hardware. So, but the reality of that is these cases, it has to do with that footprint and the cost. He can keep his costs down, charge more on, he'd have to charge more at the hospital because of the environment, is what I was trying to say.
Right. So when an employer who's self-insured understands how significant that cost differential is huge, right? It's $200,000 differential. That is really significant, claims dollars, depending on, your plan, your specific stop loss level, your, aggregate. You want to try to mitigate these things. So do you find that when an employer is implementing your solution, do they have it as like a tiered benefit so that they still give the member the choice? You can go here, but here's our plan. And under our plan, you have for inpatient care, let's just say $3,000 deductible, 30% coinsurance. We're not dictating that you have to go here, but if you go here, we'll call this the tier 1 level of benefits. If you make this smart choice to a top doctor, it costs you nothing. Do you find that employers are building the plan design to help incentivize, not force, but incentivize those members for making that smart decision?
Oh, absolutely. In fact, we have cities, we have municipalities, we have firemen unions, we have just a whole bunch of different small companies, and everyone's focused on the same thing. And the reality is they'll structure it as a tier structure plan, and they'll say, okay, good, you can go your straight commercial, or 95% of the time, the surgeons that we're working with are out of network of any plan. They don't have contracts. They're done with the insurance. And so if you were to go see them, they would hit that high deductible, high out of network billable claims and literally have to pay that coinsurance through that original commercial plan. We're like a kind of a great big discount buying club that we're literally have a direct contract with the surgeon. We negotiate the claim up front, and the employer groups recognize that we can bring that kind of value and bring this cost way down. Mm-hmm. So they literally will say, and it depends on the group, some change it a little bit, but it could be no co-insurance, no copay, no deductible to the patient. Right. If you choose to change your direction and go to work with this specialist here, have your surgery at this location, the company will pay for it. And literally, dramatically, it's such a cost savings that even our involvement in everything we're doing, it's such a cost savings to the employer. It's well worth it. Let me give a quick example. We had 17 bariatric patients over the period of 2 years. We saved the company $1.4 million on treating their bariatric patients through our program, through these out-of-network surgeons, and establishing these direct contracts. Part of that savings, about half of it, was documented that all of these patients, because of their heavy weight, were going to have spine surgery, knee surgery, hip surgery. They had bad feet. They had documented surgeries already planned in the works. They lost the weight, went through the bariatrics, and literally we had that at a great discount for what it normally cost through our program. And that was a year-long program for any of these people. That was a dedicated, on their behalf, they have worked hard to get into that, to actually get the gastric sleeve. But the reality is that employers save all kinds of money, both current on payments as well as the better health of the patient didn't have to have more procedures that are already planned.
Well, that's the thing, is that it's the future healthcare costs that you avoid by getting things done at the best doctors, right? Getting it done so that you avoid those future costs, right? Bariatrics, you name it. You don't want the infections that leads to hospitalizations, right? You're not getting that for free. You're not getting, you got an infection, MRSA, or whatever that really horrible named infection you mentioned before was.
Yes, yeah.
You got to go back to the hospital 2 days after you went home because you have an infection. Guess what? You're getting charged for all of that, regardless if it was the hospital's fault or not. One of the things that you just mentioned is really important because, a lot of people don't have out-of-network benefits anymore. So a really high percentage of people or employers have migrated to in-network only HMO or EPO style benefits. But when they do have an out-of-network benefit under a PPO or a point of service contract, it's very important that they understand that it gives the employees the flexibility to go out of network. But there is no price commitment from that doctor. And it might be one of your doctors. But when I go out of network and I have Aetna or United Healthcare, that doctor can charge me anything they want.
Mm-hmm.
My insurance company is likely to reimburse me as a percentage of Medicare, which is going to be significantly lower. And I'm going to be balance billed for the full thing. So what your solution does is says, hey, we have a contract with this doctor. We know exactly what the doctor is going to bill. And we know what your plan design is. We're going to build it into your plan design. So we're going to protect your member. I had a client, I still have him, been a client for probably about 25 years. And the reason why he's such a good client, he may not remember this, but the very first thing I worked on for him was a medical bill. There was about a $45,000 claim. And he had gone out of network. He had a PPO plan. He was referred to a top doctor. He went to the doctor and he says, oh, will you take my, I don't know, maybe at the time he had Blue Cross Blue Shield. Will you take Blue Cross Blue Shield? Yeah, I'll take Blue Cross Blue Shield. But that didn't mean the doctor was participating with Blue Cross Blue Shield. He said, yeah, I'll take it. But when he got the explanation of benefits and the bill from the doctor, his balance was $40,000.
That's where patients need to ask, are you in network with
my
insurance?
Right. In network. Are you participating? The same guy, fast forward 10 years later, had back surgery. Now he does very well. And he was having really, really bad back problems for a long time. And he did his research and he found a back surgeon. $160,000 bill. That back surgeon, because he's out of network again, that back surgeon brought in another surgeon because it was so complex. He brought in another doctor to perform the surgery with him. Problem is, you can't have two doctors billing as the primary doctor. They both tried to bill $80,000.
Yeah, no.
We got a lot of that bill wiped out, and we had to fight to come to an agreed upon amount, and he paid a lot of money at the end of the day out of his pocket. And I asked him, I won't mention his name. I said, John Doe, please don't do this again. And he said to me, Lou, I made the right choice because that was the best doctor. And my life is changed. My quality of life because of my back problems is gone. And he's happier. He walks around quicker. But he has the means. Could you imagine that being someone who's working paycheck to paycheck? They can fall victim to the exact same thing.
I can imagine it every day. I work with patients every day doing the exact same thing. Yeah. And you talked about the negotiation on that particular out-of-network claim after the fact.
Right.
What we want people to understand is we're already doing all that heavy lifting before the surgery happens. We've already gone to that surgeon and negotiated it. Because of our extensive background in billing, we did it for 20 years. When you're talking about billing for out-of-network claims, that's what we specialized in. Right. That's what we got our surgeons paid. We were very, very good at it. But the reality of that is we actually sold that company and we created this new one. And literally, we do a heavy negotiation up front. The patient knows about it. The doctor knows about it. The insurance company knows about it. Everybody signs off and agrees to it because we pre-negotiated it with them. And it's taken care of, and there's no balance billing. It's transparent up front. The surgeon comes in at a very decent, fair rate. Now, back surgery is expensive. Those implants, they don't give those away. You don't want the wood screws from Home Depot or Lowe's going into your back. You want those surgical screws, and those things, I've handled them. They look like your wood screw, but they are very high-end, sterile, and involved, and they're like $2,000 and $3,000 a piece.
what if you get the galvanized ones from Home Depot? Are those acceptable or no? Actually, I have a client. I have a client here on Long Island that's I don't know that they deal with screws, but they deal with um, they are a distributor of very high grade medical components for all the machines.
Right.
A huge, huge business, and we're talking about tens of thousands of parts and components down to the connectors between tubes. These things have to be sterile. They're very, very highly regulated, and it's expensive because of all of that. Like that screw that's coming from that manufacturer, that has to be kept sterile in a certain environment and a certain packaging for until it gets used.
Absolutely. And in fact, what the public doesn't know is, usually they don't know this, is that when, let's say you're having that total knee, or let's say that, let's just say it's a meniscus tear and the doctor has to go in and reattach things. He's got to use some nuts and bolts and screws and a plate. Mm-hmm. Well, every person's body is a different size, shape, and thing. And so he will contact the vendor for that material, for that DME that you're getting those screws in your knee to hold yourself back together. He's got to have a varied set of lengths in the room with him in the sterile environment ready to go. So the representative from the DME equipment will bring 6 to 10 different screws, and the doctor will make a precise measurement as to which one's going to actually fit that person's body. And right. That's the one they open and use. But he still has to have that supply in front of him. And so that's how much work they go through to try to take care of people. But I kind of want to digress back to one point. We're talking about the employers trying to literally look at this and how they work to save their costs. And if we had that slide up before, 20% of the cost of the total healthcare spend can be involved in surgery. And there's also no numbers that there you go, 20% for outpatient surgery. And if you notice, 30%, it could be involved in a hospital. It could be other things, or it could also possibly be some inpatient surgery. So almost 50% of your healthcare spend of any given company could be going in this direction, with 28% of it being outpatient. Mm-hmm. Well, one of the things to focus on is that out of any group of, say, 100 people, about 10% of those people every year, so 10 out of 100, are going to need surgery. So for those 10 people, that cost of those surgeries inside that hospital, if you go that direction, you're going to get hit with that 20% for just those 10 people. If you could take 7 of those and redirect them through our program, you would save hundreds and thousands, if not millions of dollars in costs out of your healthcare spend, because we literally have a supply of surgeons that can do this at a lower cost with actually a more effective surgery.
So, when you look at a health plan, right? Look, when you look at the data, it's the law of large numbers. It always agrees. It's always the same thing. About 5% of your population accounts for 80% of your healthcare costs.
Yep.
A big portion of that is the cost of the exorbitant and I think despicable prescription costs, spread pricing, rebates. You name that. That's an easy thing to fix, in my opinion, if you decide to become self-insured. And if you're self-insured today, and if there's anybody out there that's self-insured, if you're with an insurance carrier directly, you're still paying. The chances are you're still paying all of those artificial pharmacy costs. You must look at a transparent, independent type of model. There's advisors out there that are doing amazing things that even go much further than that, like just the unit cost, the actual guaranteed lowest daily cost for every medication. I mean, it's really incredible how advanced some solutions can be. So that's one thing. The other thing is not enough people have a real robust primary care system for their doctors. So many people do not even have a relationship with a primary care doctor. And those doctors, especially under the direct primary care model, where these doctors, and I talk about it every once in a while, my daughter has a direct primary care doctor, and it's night and day. these doctors, because they're not beholden to the healthcare system, they see a quarter's 25% the number of patients they had to see before. They have 30-minute, 1-hour meetings. Appointments. They don't have any staff. They don't bill insurance companies, right? And those doctors, I think, in conjunction with your solution, could be really a very powerful thing, because that doctor, can uncover a lot more, right? They can do a lot more than the typical primary care doctor can get to in 7 minutes, and I feel terrible for for primary care doctors these days, because they're so beholden to the healthcare systems. They have these quotas that are completely unattainable. They probably spend 80% of the day just inputting documents and notes, not really even taking care of people. A very small percentage of their time is even spent with people.
The other thing too, for the general public and your HR reps and anybody else involved, is a lot of that is transitioned now, and a lot of this primary care to LPNs, registered nurses, or substandard care from an actual board certified doctor.
Yeah.
And those individuals, they work hard at what they do, but just a quick example. My wife was not feeling well on a weekend, and so we went to, our doctor wasn't available. He was out of town on a vacation. So we went to one of these quick clinics just to see if we could get some information and get a diagnosis to what they thought might have been wrong with her. So she filled out the intake forms and put down what her symptoms were. And as soon as the physician's assistant walked through the door, she announced, before she ever saw the patient, she says, "Oh, you're here for this?" And she declared what the diagnosis was before she even examined or talked to my wife. And she was a physician's assistant. And my wife, who will stand up for herself, just looked at her and says, "No, that is not what I'm here for. I definitely know what that disease is, and I don't have it. I'm suffering from other symptoms, and the following symptoms for that disease would be the following, and I don't have any of those symptoms, but I have other issues I want to talk to you about." And it was amazing to see that physician assistant, just because they're seeing so many people and everything else, she'd already made her mind up before she ever walked through the door.
Yeah.
It's like, if you're not seeing a board certified surgeon, and even if you are, as a public person, or don't be afraid of that white coat and ask as many questions as you want.
Yeah.
They're making educated guesses. They're fantastic people. They care about people. But if you get to the bottom of your healthcare, it's your body, and you got to go home and live with the results. So you ask all the questions you want and get a true understanding of your best choices before you go through that situation, especially in surgery. You want to know, well, what can the side effects be? What's the outcome? Am I going to have recovery time? Do I need physical therapy? What's going on here?
Right.
What are the choices? What other choices? Who else in this industry would you recommend talking to for a second consult? Those are all valid questions, because it's your healthcare and you need to own it and take care of it.
So I have a pretty extreme example, but I have a good friend, again, not going to mention any names, who had a skiing accident probably about 15 years ago, probably a good guess, and was skiing. He was actually off the slopes. He was skiing back to the guest house he was staying in, and hit a boulder that was sticking out of the ground. And his skate went directly into the boulder and twisted, and he got a spiral break of the ankle.
Oh, wow.
It tore the ankle. It wasn't a break. It shredded.
Ouch.
Immediately got, rushed to the local hospital, talked to a couple of specialists. They were about to amputate.
Oh.
It was so bad. They're like, we can't do surgery. There's nothing left to be able to use material, screws, bolts, whatever, to put it together. And he said, no, take the pain away. And he got, he I don't know where he was at the time, probably New Hampshire or somewhere like that. Went to one of the hospitals, one of the premier hospitals in New York City, and they made him comfortable. And they said, listen, they're probably right. They're probably right, because this is severe. This is one of the worst we've ever seen. But there's 2 doctors in the country that we would like to send your
Information, your X-rays.
radiation, the MRIs, CAT scans, X-rays to,
Yeah.
it's gonna take them a day or two to get back to us, but we're not giving up hope yet. And they sent it, and it was actually a expert surgeon I think it was in Denver, it was in Colorado somewhere. He flew there. They flew him there, or he flew there. I think he went there. I don't think the doctor came here. I'm pretty sure that he got his way there somehow, and he had the surgery. But they were, when you think about that, right? I mean, when it's time that you need to have a network of people who can find the absolute best, that doctor didn't belong, by the way, to any healthcare plans. He was lucky enough to be one of the people that had an out-of-network benefit. It cost him. But I believe, going back 15 years ago, that he talked about price with the doctor. He wasn't afraid to say, "What's this going to cost me? What is this going to cost?" Had he had your solution, you guys could have had that conversation for him, and probably, right, set some examples for him and say, "Okay, well, this is the range." I know that you're familiar with the Oklahoma City Surgery Center.
Yes.
Right. And I use it as an example only because I invite people to go on their website, not because it's a place to go necessarily. And I don't even know if it's in your network, so I apologize if it's not, but to look at the prices, like what healthcare can be, where they just post the prices. Here's our price. We don't deal with insurance carriers. It's not about Oxford's price or Cigna's price or United's price or Blue Cross price. This is what we charge for that procedure. And I think that's what you're bringing on a much larger scale, is the ability to say, hey, you can have these treatment, what did you say, 2,000 procedures?
On what? And how many procedures are out there?
Well, that technically could fall under the umbrella of your ambulatory, centers. What they?
No, there's about 5,700.
Wow.
Procedures that can go under that. That's the actual CPT codes that are designed for surgery. There's that many different types of surgery. Yes.
So in the last couple of minutes that we have, because we're coming up on the hour pretty soon, so just take me through the process. An employer who's self-insured looks at this and said, "We want this." You could probably, if they gave you data on the procedures that their employees went through the last year, I'm sure you could probably do a cost analysis and said, "This is what we paid. What would these have cost, these codes, with you?" Right? And they decide, we want to do this. And now it's part of the package. How does the member experience work? Like, I have it and I need a surgery.
Well, the member experience can work in a couple of ways. First of all, we like to try to help everybody educate their members so they know about us. That's kind of important, just that they understand who we are and what we do. Right. But the member experience is really straightforward. First of all, let's back up a second before we get to the member. We're a bolt-on service, and we're listed as an actual benefit. But we could be enrolled in the middle of the year. We don't have to wait to open enrollment. Right. You just sign us up, get us involved, sign our contract, and away we go, because our network and doctors are waiting there ready to do surgery. So, and with the way COVID's been, people don't want to have elective surgeries, but some of them are hobbling around and really need some help. Right. So the plan could literally add it on in mid-year. And once it's added on, we're usually, like you said, in a tier structure where we're for anything out of network or an elective surgery, and you want to go to a certain specialist and they're out of network, they have nothing to do with Blue Cross or any of the BUCAs. And the patient experience is really easy because they sign some medical release forms and we do all the rest of the heavy lifting. We will, behind the scenes, contact their primary care doctor and get their medical records to send to the surgeon with the imaging, if imaging's already been done, and if not, we'll schedule for imaging for, say, like an orthopedic surgery. All of that is set up by us behind the scenes. We've talked to the patient, got their approval. the surgeon says, I'll do a consult. I want to talk to this patient. I want to see what's going on. He'll look at his imagery and say, yes, what do you know? She does need surgery. At that point, we then negotiate with the surgeon, the surgery center, and the anesthesiologist to provide a bundled claim of what it's going to cost to have that surgery. And it depends on how the plan lists us. Some plans have a smaller copay, say $500. Some plans waive the copay or the deductible. It just depends on how it's written into the plan. But at that point, we then notify, and the patient knows what they're going to have to pay or not pay. And they schedule in and do the consult and the surgery. And then after the surgery, we handle all the billing from these entities to the TPA that's involved, the third party plan administrator. And so all that's taken care of, and there is no balance billing. There's no problems with the doctors or surgeons or anesthesiologists because they've already agreed up front what they're going to get paid on.
Right.
And of course, we can also bundle for like orthopedic cases, for example. If there needs to be physical therapy, we can actually include that in the bundle because the doctor will let us know that needs to happen, like a total knee or even a meniscus tear. There needs to be therapy going on afterwards. We'll include it in the bundle and get it taken care of.
So now, if I'm an employee and I'm aware of this benefit,
I can't hear you.
Oh, you
can't hear me? Why?
Can you hear me now? I think my sound is working.
I'm good.
You can't hear me, huh? How about now?
Are you good with hand signals?
Can you hear me now?
I don't know what happened here.
No? Oh, my sound seems to be working. I can hear you fine. Oh boy.
Well, I can't hear you, but I don't know why.
Hold on, let me check.
Anyway. Okay.
Audio.
So what would you like to do?
How about now? Can you hear me now? My sound seems to be okay. I wonder if it's your interesting.
Send you a quick text.
Yeah. Well, I'm hoping that people can hear me.
I'm just typing a quick note in here.
Yeah. I'm gonna keep talking for just 2 minutes.
Okay, let's do that.
Yeah. So
I'm gonna leave and come back in.
Yeah, we'll see what happens. Hopefully you guys can still hear me. My audio seems to still be fine. I'm not sure what was going on there with Kelly, but anyway, thank you for joining us today. Kelly's a great resource. I'm going to put up his contact information here: Exclusive Surgical Solutions, or ESurgeries.com. I don't know. Can you hear me now?
I can hear you now.
Okay. I think I was okay the whole time. I'm not sure if it was just something on your side, but hopefully we were good. I just put this up. I want to thank you, for because we're coming up on an hour right now. But what I was going to ask you real quick, and I'll just jump in there. Is, so if my employer implements this and I'm aware of it, right? That's obviously education and awareness is super important. And I need a surgery. Can I rely on your team to help me find the best one within a reasonable? Okay, because that's really important, right? Is finding the best doctor, knowing that God forbid it's you or a loved one that needs back surgery. It's so easy to say, but getting a back surgery in your 40s, 50s, 60s, you have to live with the results of that for a very long time. Ankles, knees, hips. You don't want that to go wrong. And like you said before, any orthopedic surgeon is probably qualified to do it. They're allowed to do it. That doesn't mean they should be doing it.
Correct.
Right? And, there's some that are experts on shoulders, hands, knees, backs, legs. You want to find that one. People, I bring it up all the time, but, the head of orthopedic surgery at a particular hospital is not necessarily the best surgeon, is more likely to be the biggest moneymaker for that hospital.
Correct.
You know what I mean? And that means they do a lot of surgeries. Doesn't mean they get the best results. Sometimes more money for the hospital means inferior results, longer hospital stays, infections. Not that we're trying to do those things, I don't think. Hopefully, no one out there is trying to do that.
I've had conversations with board certified surgeons that was the exact reason that they wanted to leave the hospital, go out on their own, is because they just couldn't live and think about the fact that they were doing unneeded, unnecessary surgeries and they were being kind of pushed into them. And
Wow.
so they wanted to treat the patients instead of helping the hospital system make money.
Yeah, it's just not acceptable. And we have to, as a consumer, we have to think about ourselves as consumers of healthcare. That's why we're buying insurance. You're not buying insurance, right? You're buying healthcare. You're financing access to healthcare for your employees with insurance. So it's a necessary evil, but you need to understand that information is out there. There are people that are willing to help employers and their members kind of unbundle or get out of the trap that they've fallen into with just following the health insurance carriers down a very, very dark path. That's why the name of my agency is Bright Path, right? Because that's our strategy. That's our solution, right? It's exciting to go to work when you know that there's so many people you can help. And I'm sure that you love every day what you're doing because you're helping people get better results. And it's not just that person whose life is altered by getting the best surgery at a high quality provider, but think about all of the people in that person's lives that benefit from that person having better results, less of a medical expense. I mean, bankruptcy, and I'm sure a lot of it has to do with surgeries, like the things that happen in the hospitals that you can potentially solve for. I think it's 70% of all bankruptcies are healthcare related, and those people, majority of them, had health insurance. They
Yeah.
just didn't get the proper guidance and they didn't get the proper care, and they weren't dealing with people, who found a better way to do things, and then unfortunately, that message is not loud and clear enough, but with help with people like you and hopefully people like me, we can get the word around and help people understand that there's a better way.
We'd love to help out, and I'm glad you're in here mixing it up and telling people about it. So that's great.
I'm trying my hardest. Are you going to be in Austin?
Yes, I will.
I will see you probably Monday. I'll be at Benefits Pro.
I'll
A
be
lot
there.
of time away from the office, but it's for a good reason. So that's how we learn, right?
Yep.
Awesome.
We'll
Well,
be
I
there. We'll make
appreciate
some
it.
time.
Yeah. Well, I appreciate it. Thank you. This was great. I'm going to end the broadcast now. If you have any questions, please reach out to Kelly and I, and hopefully the broadcast went well. I had some messages earlier. Might not have been live on LinkedIn the entire time, but I think the video recording was. So we'll share
Okay,
it with
good.
everybody.
All right.
Thanks a lot.
See you
Take
later.
care. Bye-bye.